So when do you do? It is in type 1, you do the first examination 3 to 5 years after diagnosis and yearly thereafter. Type 2, you do at the diagnosis and yearly thereafter. In pregnancy, you do prior to conception and during the first trimester. Now this in pregnancy is very important because if you have microalbuminuria in pregnancy in a first trimester, it predicts PIH in this patient, hypertension occurring in the third trimester, and then I need to be very careful about diabetic control for this patient. So I think that assessment is very important. And once you get a test positive for microalbuminuria, then you try and look at any condition which can cause this falsely positive microalbuminuria. If the answer is no, then you repeat the microalbuminuria test twice within 3 to 6 months again. And if these 2 to 3 tests are positive, then you need to start treatment. So treatments are available for reducing microalbuminuria because this prevents the progression of diabetic nephropathy. So this is the algorithm to be followed if you have a pure diabetic albuminuria patient who is not having albuminuria due to stress, exercise, infection, or anything secondary which can be treated. So if there is any secondary cause, then you need to treat that and again reassess. And if the patient is negative, then you assess annually. And you need to take it very seriously. As clinicians, microalbuminuria is taken as a very serious complication. Why is it important? Because it's an early marker of renal damage. The degree of microalbuminuria is directly proportional to the degree of damage, and the regression of this microalbuminuria decreases the risk. So you are doing some benefit by diagnosing and treating it timely. It's a marker of a generalized cardiovascular risk. So it implies that the CVD risk is very high in this patient. These patients are prone for getting early heart attacks and ischemic manifestations. It is a sensitive, reliable and accessible test. And it is a very good clinical marker of all the endothelial function in the body. So it shows the marking of each and every blood vessel in the body. So you can diagnose all the microvascular and macrovascular disease based on a simple test like this. So JNC7 actually recommends annual screening of microalbuminuria even for hypertensive patients, even if they are not diabetic, even for dyslipidemic patients, even if they are not diabetic. So that's the way it goes. Why is it so? Because as the microalbuminuria increases, the mortality, if you have a higher level of microalbuminuria, the mortality is significantly high. So it is a predictor of mortality in patients with cardiovascular disorders and diabetes. So it is an important marker. So how do you test it? There are 3 methods: timed urine collection, either 24 hours or overnight, early morning urine sample. This can help to calculate the albumin excretion rate, and the spot urine sample. So spot urine is what we prefer because it is easy for the patient in a single setting. Standardizations are good and you don't need lot of collection techniques involved into that. So the patient is also comfortable. But of course one needs to remember that it is related to the sex of the patient, the posture, the exercise, fever, the amount of diabetic glycemic status control which determines this. So these are the values recommended. This is a net copied slide and it shows the range. Now normally this is what we do in our practice. Spot sample for collection of albumin. So it is measured as microgram per milligram of creatinine. Now here I was told by Dr. Patwardhan that you need to do the creatinine by the IDMS method. I really don't know the method, but if the creatinine is done appropriately, then you can actually apply this methodology. So this range of microalbuminuria needs to be definitely treated and assessed with caution, and more than 300 needs to be an alarming sign. So it definitely needs to be followed up at regular intervals. So, and as I said, if you are using protein as a guideline, then you need to follow these levels of proteinuria. So I would prefer that you don't use protein into the monitoring scenario, use albumin, because the therapeutic studies for treatment of microalbuminuria also have been done with albumin evaluation. So which test? Most accurate test, if you want, it is 24 hours collection. But most convenient, it is USER. So that's the best answer I can give you at this moment. And recommendation is to measure urine albumin and serum creatinine at diagnosis and annually thereafter in a patient with stable diabetes. What about eGFR? You have either creat clearance measured by this formula, and EGFR measured by this formula, but you need not measure by the formulas. You have calculators online, you just have to feed it up and you get the ready value. I would appreciate if you incorporate into your reports. So that will give me additional relief from me doing that. Then you have something like urinary and serum cystatin C, and as I said that the earliest marker, normally what happens is this cystatin flows freely in and out of the kidney. So you have a normal level of cystatin in the serum. Now when the patient has early renal damage, this is the molecule which starts accumulating, both in the urine as well as in the blood. So a high cystatin level is immediate and early and upcoming marker. But of course it's not a very specific marker because there are a lot of neurological diseases involved or other organ diseases which can also give rise to high cystatin. So I would not recommend this at this moment of time, but we need to have more data on that in future. Then you come to lipid assessment. Now what we would do is that the lipid assessment, dyslipidemia is a very common manifestation of diabetes, and if you see, most of the diabetic deaths are due to cardiovascular disease and dyslipidemia. So lipid profile again has a lot of controversy. So whether I should do only cholesterol, only triglyceride, only one lipid, all, should I do all, should I do mini, should I do max, should I do a complete active form, and should I do a recent one, a new form, or should I do ApoA, should I do ApoB? All these questions come to me daily. So what I thought is that the question simply answered is that you need to do a overnight fasting. There is no need of 14 hours fasting. This is a misconcept that fasting will help in better assessment of lipid profile. Only triglycerides are affected by fasting status and postprandial status. Most of the times all the lipids are stable. So even if you check it in the postprandial, it will not show a lot of variation. So the common test is that you do a overnight fasting. So when you are doing a sugar, you do the lipid profile. That's the best thing. And secondly, which one is most important? So all are more important provided your clinician understands how to read it. So basically the interpretation of the lipid profile is very important when you are reading a lipid report. And not only is the quantity, but the quality. That is a very important factor. So the LDL size, the particle number, and HDL size and number, all these are parameters which really we can't assess, but we need to understand that lipids are more than that report. So that is what we need to do it in a regular base. So we have, what as a clinician I am interested in is non-HDL cholesterol and the HDL cholesterol. So I know that HDL is a good cholesterol and everything beyond HDL is a bad cholesterol. So I have to have this value, or total cholesterol minus HDLC, which gives me some clue to the atherogenicity of the blood. So atherogenicity of the blood decides how the patient is at risk of macrovascular complications. So definitely if I have a complete comprehensive lipid profile, I am very happy. But if the patient, for the purpose of cost, is not able to perform, then total cholesterol and HDLC, these two parameters are enough to guide me to the atherogenicity of that patient. So I have guidelines which will help me that it needs to be maintained below 130 for the diabetic patient. So these are the minimum basic which would be recommended. Now if you see in the dyslipidemia in diabetic patient, you get all these abnormalities. So you get increased triglyceride, VLDL, LDL, small dense LDL, ApoB, and there is a decrease in the HDL and ApoA1. So there is a decrease in the cleansing system. So these are cleansers of the body. So they clean all your lipids. Now these cleansers are less in the body, and that's why atherogenicity increases with all this. So I'm interested in reducing this and increasing this as a clinician.